Welcome, everyone. Today we'll be diving into the fascinating and complex world of neurological disorders. We'll be exploring conditions that affect the brain and nervous system, impacting cognitive and perceptual functions. This is a critical area for nurses, as neurological issues can present in diverse and challenging ways. Our journey begins with a structured approach. We'll start by reviewing the fundamentals of neurological assessment. Then, we'll compare and contrast different types of headaches, focusing on key assessment findings. Next, we'll differentiate between various seizure types, including their clinical manifestations and management strategies. Finally, we'll explain the crucial role nurses play in implementing seizure precautions. We'll be discussing the acute management of seizures and status epilepticus, a critical neurological emergency. We'll also prioritize nursing care for patients with meningitis and encephalitis, two serious infections of the central nervous system. Finally, we'll discuss the etiology and management of Huntington's disease, a progressive and debilitating genetic disorder. We'll begin with status epilepticus, a neurologic emergency where seizures don't stop and can damage the brain. Then, we'll talk about meningitis and encephalitis, two central nervous system infections that can cause severe complications if not treated quickly. Finally, we'll introduce Huntington's disease, a genetic progressive disorder that affects movement, mood, and thinking. It's heartbreaking, but understanding it helps us provide compassionate care. Headaches are a common complaint, but understanding their nuances is essential. We'll be comparing different types of headaches, focusing on their characteristics, triggers, and appropriate interventions. This knowledge will enable you to provide targeted and effective care to patients experiencing head pain. Some are sharp and stabbing, others dull and throbbing, and each type has its own triggers, symptoms, and treatment. We'll compare migraine headaches, intense, often one-sided, with nausea and light sensitivity, tension headaches, tight, band-like pain around the head cluster headaches, rare but severely painful, around one eye, sinus, TMJ headaches, associated with facial pain or jaw movement. Let's look at this scenario. Your patient says, "It feels like someone is tightening a band around my forehead." What type of headache does that sound like? That's right, tension. Migraine headaches are more than just a bad headache. They're episodic, familial disorders often characterized by intense, throbbing pain. We'll explore the underlying mechanisms, including the role of blood vessel dilation and constriction, and discuss the associated symptoms like nausea, dizziness, and visual disturbances. Migraines often have a genetic link and involve changes in blood flow and nerve signals. The pain is usually unilateral, one-sided, located in the frontotemporal area and described as throbbing or pulsating. They can be debilitating with symptoms like nausea and vomiting, light sensitivity, photophobia, sound sensitivity, phonophobia, dizziness or visual disturbances. Migraines with aura often progress through distinct phases. The prodromal phase, or phase 1, is characterized by the development of an aura. This can manifest as visual disturbances, such as flashing lights or shimmering lines, or neurological changes like numbness and tingling. Recognizing these early signs is crucial for timely intervention. In phase 1, the aura phase, patients may see flashing lights, zigzag lines, or experience numbness and tingling in the lips, tongue, or limbs. These symptoms can be scary if you don't know what's happening. Scenario: a patient tells you, "I saw bright lines and then my left hand went numb." That's a classic aura. Recognizing it early can allow for timely treatment and potentially reduce the severity of the migraine. The second and third phases of a migraine with aura bring increasing intensity. Nausea and vomiting may develop, and the pain, often starting in the temple, intensifies. Eventually, the pain becomes dull, and the headache can last anywhere from 4 to 72 hours. Understanding this progression helps us anticipate and manage patient needs. Phases 2 and 3 can include nausea and vomiting, sensitivity to light, sound, and even smells, migraine duration, 4 to 72 hours. This is when patients need quiet, dark rooms and fast acting meds. Managing migraines with aura involves a multifaceted approach. Treatment options range from pain relievers and triptans to anti-nausea drugs and even Botox injections. We'll also discuss the role of antidepressants, antihypertensives, anticonvulsants, and alternative therapies like acupuncture in migraine management. We can use triptans for acute attacks, antiemetics to reduce nausea, Botox injections for chronic cases, antidepressants, anticonvulsants, and antihypertensives for prevention. Don't forget, some patients benefit from acupuncture, biofeedback, or lifestyle changes like sleep regulation and stress reduction. Migraines without aura share some similarities with those with aura, but also have distinct features. We'll explore the phases and mood changes associated with these migraines, as well as the characteristics of the pain, including its unilateral nature, pulsating quality, and sensitivity to light and sound. Symptoms include unilateral, pulsating pain, photophobia, and phonophobia, mood swings, irritability, and fatigue before the headache strikes. Tip: these patients may misattribute their symptoms to stress. Asking the right questions is key to diagnosis. Cluster headaches are known for their intense, debilitating pain. The pain is typically unilateral, deep, and located around the eyes. Other symptoms include tearing, rhinorrhea, and facial flushing or pallor. Patients often exhibit restlessness, pacing, or rocking during these excruciating episodes, which can last from 15 minutes to 3 hours. Pain is unilateral, one-sided, focused around the eye, accompanied by tearing, nasal discharge, flushing, or sweating. Patients are often restless, pacing, or rocking in pain. These can last 15 minutes to 3 hours, often at the same time each day. Effective management of cluster headaches requires prompt intervention. Administering 100% oxygen via mask can provide significant relief. Maintaining a consistent sleep-wake cycle and identifying and decreasing precipitating factors are also crucial for preventing future attacks. Treatment includes 100% oxygen by mask, fast relief, preventive meds like verapamil, encouraging regular sleep and avoiding triggers. Patients may need education about tracking patterns to predict episodes. There are many different types of headaches, each with its own unique characteristics, from TMJ and sinus headaches to cluster, tension, and migraine headaches. Understanding the distinctions in pain location and associated symptoms is key to accurate diagnosis and treatment. TMJ, jaw clenching or chewing triggers. Pain sinus, pressure pain in the cheeks, forehead with nasal congestion. Tension, tight band around the head cluster. Sharp, stabbing pain behind one eye, migraine. Throbbing, pulsating pain with systemic symptoms. Tip: always ask about location, duration, and associated symptoms. Preventative medications play a vital role in managing chronic headaches. Beta blockers, antidepressants, calcium channel blockers, and Depakote are commonly used to reduce the frequency and severity of attacks. We'll discuss the mechanisms of action and potential side effects of these medications. Medications include beta blockers like propranolol, antidepressants, amitriptyline, calcium channel blockers, verapamil, anticonvulsants, Depakote. Patients need consistent dosing, routine monitoring, and encouragement to stay on track even if headaches subside. When a headache strikes, attack aborting medications can provide rapid relief. Imitrex, a vasoconstrictor, is often used to treat migraines. For general pain management, Simple analgesics like Tylenol, NSAIDs to decrease inflammation, and in some cases, narcotic analgesics may be appropriate. Triptans, e.g., Imitrex, work by constricting dilated vessels, NSAIDs, reduce inflammation, acetaminophen, for mild pain opioids, reserved for last-line cases. Caution. Overuse can lead to rebound headaches. Educate patients on safe usage. Dietary factors can significantly impact headache frequency and severity. Certain foods, such as processed meats containing nitrites, aged cheese containing tyramine, sugary snacks with aspartame, foods containing monosodium glutamate, MSG, and caffeine, can trigger headaches in susceptible individuals. Common triggers include aged cheeses, tyramine, cured meats, nitrites, MSG in fast food or packaged snacks, aspartame, caffeine. Epilepsy is a chronic neurological disorder characterized by recurrent, unprovoked seizures. A seizure, on the other hand, is an abnormal, sudden, excessive discharge of electrical activity in the brain. Understanding the difference between these two concepts is fundamental to providing appropriate care. A seizure is a single event, like a lightning strike in the brain. Epilepsy means recurrent, unprovoked seizures. Analogy: seizures conquer storms. Epilepsy, a climate where storms occur often. Seizures are classified based on their onset and characteristics. They can be focal, generalized, or of unknown origin. Further categorization includes motor and non-motor types. This classification system helps us understand the underlying mechanisms and tailor treatment accordingly. Focal starts in one part of the brain, generalized, involves both hemispheres, unknown origin. When cause isn't clear, subtypes include motor, jerking, and non-motor, staring, confusion. Generalized tonic-clonic seizures are characterized by distinct phases. The tonic phase involves stiffening of the muscles and loss of consciousness, while the clonic phase involves rhythmic jerking of the extremities. These seizures typically last 2 to 5 minutes and require careful monitoring and management. Tonic phase, body stiffens, loss of consciousness. Clonic phase, jerking movements, may bite tongue, become incontinent, lasts 2 to 5 minutes, followed by postictal fatigue. Safety, clear area, turn patient on side, time the seizure. Generalized absence seizures are more common in children and often have a familial component. They involve brief periods of loss of consciousness and blank staring. The individual typically returns to baseline immediately after the seizure, but these episodes can interfere with daily activities. Brief episodes of staring or eye fluttering may occur dozens of times a day. Child zones out but resumes quickly. Impact can affect learning. Teachers may be the first to notice. Generalized myoclonic seizures involve brief jerking or stiffening of the extremities. These movements can occur singly or in groups and typically last only a few seconds. Understanding the characteristic movements and EEG patterns is crucial for accurate diagnosis. Can occur in clusters. Usually no loss of consciousness, can be subtle, like a quick shoulder twitch. Tip: ask patients about shocks in the limbs. Generalized atonic seizures are characterized by a sudden loss of muscle tone, lasting for seconds, followed by postictal confusion. These seizures can cause the individual to fall, highlighting the importance of safety precautions. Sudden loss of muscle tone, risk of falls, and head injury, postictal confusion, common nursing care. Ensure patient uses helmets if prescribed, and environment is fall safe. Simple partial seizures involve specific areas of the brain, resulting in a variety of symptoms depending on the affected region. The individual remains conscious and may report an aura. Symptoms can include motor, sensory, olfactory, auditory, or visual disturbances. The symptoms of simple partial seizures depend on the specific area of the brain involved. For example, Involvement of the motor cortex can lead to focal motor movements, while involvement of the sensory cortex can cause somatosensory tingling. Understanding these correlations is essential for localization. Complex partial seizures involve a loss of consciousness for 1 to 3 minutes. Automatisms, such as lip smacking or picking at clothes, may occur, and the individual is typically unaware of their behavior. Amnesia is common after the seizure, and the temporal lobe is often the most affected area. Complex partial seizures can manifest in a variety of ways, including impairment of consciousness, dreamy states, auditory and visual hallucinations, unusual smells, psychomotor phenomena, and dysphagia. Recognizing these diverse symptoms is crucial for accurate diagnosis and management. The etiology of seizures is diverse and can include metabolic disorders, acute alcohol withdrawal, electrolyte imbalances, high fever, stroke, head injury, substance abuse, and heart disease. Identifying potential causes is essential for targeted prevention and treatment. Diagnosing seizures involves a variety of tools. An electroencephalogram, EEG, is used to measure brain activity, while CT scans, MRIs, and PET scans can help identify structural abnormalities or metabolic changes in the brain. Computed tomography, CT, scans provide detailed images of the brain, allowing us to identify structural abnormalities that may be contributing to seizures. These scans are particularly useful in detecting tumors, hemorrhages, and other lesions. Drug therapy is a cornerstone of seizure management. Antiepileptic drugs, also known as anticonvulsants, are typically introduced one at a time. Seizure control may require a combination of drugs, such as dilantin, Ativan, Depakote, and clonopin. Seizure precautions are essential for ensuring patient safety. These include having oxygen and suctioning equipment readily available, inserting a saline lock, raising side rails, lowering the bed, turning the client on their side, and avoiding restraint. During a seizure, it's crucial to protect the individual from injury. Gently guide them to the floor, turn them onto their side, and remove any objects that could cause harm. Do not put anything in their mouth or try to restrain their movements. Status epilepticus is a neurological emergency, defined as prolonged seizures lasting more than 5 minutes or repeated seizures over the course of 30 minutes. Causes can include acute alcohol withdrawal, head trauma, cerebral edema, and metabolic disturbances. Prompt and aggressive treatment is essential. Drug treatment for status epilepticus typically involves intravenous medications such as diazepam, Valium, and lorazepam, Ativan, which is often the drug of choice. Diazepam gel Diastat can also be used. Phenytoin dilantin requires careful administration due to compatibility issues. Electroencephalography, EEG, plays a crucial role in diagnosing and monitoring seizure activity. This non-invasive test measures brain activity through electrodes placed on the scalp, providing valuable information about seizure type and location. Surgical management of seizures is an option for patients who do not respond to medication. Vagal nerve stimulation, VNS, involves stimulating the vagus nerve with a magnet during an aura to abort the seizure. The RNS system is another option for proven seizure control. Corpus callosotomy is a surgical procedure that involves cutting the nerve tracts, corpus callosum, between the cerebral hemispheres. This reduces the number and severity of seizures by preventing the spread of electrical activity from one side of the brain to the other. Viral meningitis is an inflammation of the meninges and cerebrospinal fluid, CSF. It is typically caused by a viral infection transmitted through the bloodstream. Unlike bacterial meningitis, viral meningitis does not typically involve the formation of exudate. Bacterial meningitis is a medical emergency caused by a bacterial infection transmitted through the bloodstream or via a direct route. Symptoms include headache, altered mental status, photophobia, neck stiffness, high fever, and petechiae. In bacterial meningitis, exudate forms, which can further irritate spinal and cranial nerves. Meningococcal meningitis can be epidemic in nature, highlighting the importance of prompt diagnosis and treatment to prevent widespread infection. Encephalitis is an inflammation of the brain tissue, typically caused by a viral infection transmitted through the bloodstream. Mosquitoes are a common vector for viral encephalitis. Encephalitis does not typically involve the formation of exudate, but it can cause degeneration of the neurons of the cortex. Demyelination of axons can occur, leading to hemorrhage, edema, necrosis, and increased intracranial pressure, ICP. Meningitis and encephalitis share several clinical manifestations, including photophobia, headache, nausea, vomiting, fever, neutral rigidity, seizures, and focal neurologic deficits. Recognizing these signs and symptoms is crucial for early diagnosis and intervention. Complications of meningitis and encephalitis can be severe and include increased intracranial pressure, ICP, herniation of the brain, death, SIADH, septic emboli, DIC, hemiparesis, and death. Prompt and aggressive treatment is essential to minimize these risks. Diagnosing meningitis and encephalitis involves a variety of laboratory tests, including CSF analysis, CBC, WBC count, and serum electrolytes. Blood cultures, chest x-rays, and CT or MRI scans may also be performed. Managing neurologic infections requires a comprehensive approach. Prioritize ABCs, monitor vital signs, and perform neurochecks every 2 to 4 hours. Assess cranial nerves, and manage pain effectively. Best practices for managing neurologic infections include administering medications and IV fluids, maintaining strict I&O, elevating the head of the bed to 30 degrees, reducing stimuli, and maintaining isolation for meningitis. Standard precautions for droplet isolation are also essential.